and try and go to my, here. Oh. Hi everybody, my name is Simon Darnley. I'm head of the Anxiety Disorders Residential Unit at the Bethlem Royal Hospital. We specialise in inpatient treatment of obsessional compulsive disorder and body dysmorphic disorder, but we also run a specialist outpatient habit disorders clinic which covers trichotillomania and skin picking. And so my presentation today is hopefully not too long and not too laborious on trichotillomania and skin picking and how to beat them. And hopefully we'll have loads of questions afterwards that we can really get into finding out what you want to know and learn about the problem, how you go about beating it, and the treatment for it as well. Okay, some of these things you will hopefully all know. I'm going to start with trichotillomania first of all, and then relate it to skin picking. We see them both as habit disorders. Trichotillomania actually means from hair pull madness initially. There is a DSM-4 definition of trichotillomania. There are problems with it. Recurrent hair pulling with noticeable hair loss, also tension before pulling or when attempting to resist, and pleasure and gratification or relief after the pulling. Now what we know is that in fact about 40% of people don't get the tension before pulling. Often this can be they're actually not aware, so they're aware that they're pulling, and it's only when they've pulled out enough they've caused a problem, they think, oh, I've done that again. I mean, I kind of often see it's like when you watch a film with a big tub of popcorn, for example, and you start eating and eating, you don't realise, because you're into the film, you suddenly realise the popcorn's all gone. It can come into your what we call pre-consciousness of this hair. So hair pulling can work in the same way. Also, often people, there's a big percentage of people who don't get the pleasure and gratification or the relief when they've pulled the hair. They can often feel shame or embarrassment or disgust, actually, the fact that they've done that. So there are problems with the DSM. It's important too that it's not better accounted for by another disorder or a general medical condition. They're fairly rare, though. What is important, and what's recently added, is the amount of distress and impairment this has on people's lives. Skin picking is the same, but the actual definition of skin picking and defining it is a nightmare again. It comes under the impulse control disorders, and in the impulse control disorders, and I think this is totally unsuitable, are things like pyromania and pathological gambling as well. And under that, there's a kind of non-specific side of it, not otherwise specified, and as you can see, that includes skin picking, and it's in there as just, for example, skin picking or compulsive shopping. So it's really kind of not well defined or recognised yet, and this is not particularly, I don't think, a very reasonable thing to put them in the same category. So we would like to kind of go, and at the moment they're looking for the new DSM category, and it's being discussed now, and actually looking at recommending classifying these disorders as body-focused repetitive behaviours. So these things all have similar traits, and there's a repetitive, there may be self-smoothing or body-focused grooming-type behaviours. And the types of examples covers the trichotillomania, the compulsive hair pulling, also compulsive skin picking, but in there as well would include excessive nail biting, excessive cheek biting, nose picking or lip picking. We'd also want to hear there may be even bruxism where people grind the teeth or try to get those things there. I mean, especially with trichotillomania and skin picking, I know that kind of wanting to get the piece of skin right and wanting to get rid of that little nub or hard bit or bit of loose skin you see can get to be quite a feature of the problem, and you're actually kind of digging and trying to find that little bit and get it smooth in that sense as well. So hopefully these things are going to be reclassified as what we call body-focused repetitive behaviours. Okay, the prevalence. In the prevalence, it's estimated, people don't quite know. It varies between by 0.6% to about 3.4%. What we do know is if you relax the criteria at all, in a student population, it's about 10% of students in that sense. What people pull. So how? We see it as two areas. One is automatic, And these are things where you would actually be pulling or picking, if you're saying skin picking, or scratching, where the attention is focused elsewhere. So this may be a good example will be on the phone now. You may be on the phone, concentrating on what you're doing, and your other hand then goes to your hair, and you start twirling the hair around, kind of pre-consciously. So you're not really aware of it, and then you find something, you feel it, you find a little hard bit, and then you want to twist and pull that. So this tends to happen while you're doing other activities, and it would almost be when you're in a trance-like state. Sometimes this happens for people when they're stressed. If they're on the phone and they're having a difficult conversation with, say, a partner or a family friend or one that's causing stress, then it may increase the behavior in that sense as well. We know that. The other type will be focused. Here, the attention is actually focused on the act of pulling or in skin picking, the act of getting the skin and wanting to pick the skin specifically. Then here you may stop all other activity, focus on it. You may use mirrors, tweezers and other devices to actually try and get in there and try and get the bit that you want. This may be ritualistic and has similar patterns or rules about how you go about that, how you make sure you get the right light, or how you make sure the type of things you will pull. The most common areas, as you can see from the slide, are mostly scalp, and then it's kind of facial areas and then other areas of the body. For children as well, because it is a problem in children, you can see that the areas again tend to be around the scalp, more around the scalp, and then you can see the percentage for the other areas of the body as well. I can see when I've got 100% of people watching this screen now. That's interesting. Right. Common behaviours that people do would include extracting the hair bulb completely intact, biting or mincing the hair up, often rubbing the lips or face with the hair, and like I said, it can often be in a set pattern. There's often kind of placing or saving or discarding the hairs in a set way, or twirling or rolling or examining them in the fingers as well. There's often associated with a search for hairs that don't feel right, either too coarse or too curly, or split ends, that sort of thing, or ones that don't look right. So you're looking for grey ones particularly in that sense as well. Sometimes there is a kind of compulsion to make the hairline absolutely even, and therefore sometimes you can see that's associated with maybe BDD-like behaviour in that sense. One of the big issues is that people swallow or eat the hair, which is quite common. Sometimes people will rub their hair up between their teeth, backwards and forwards in that sense. If they do swallow it, and you can have hairballs, which are, I suppose, an issue of this. It causes real problems for some people. If they do rub it on the lip and ingest part or all of the hair, because hair is non-digestible. So that can cause a hairball in the stomach, which at its worst, and it would take a long time for it to build up, it can become life-threatening and need to be removed. The big thing about trichotillomania and skin picking is that many individuals go to great lengths to hide the evidence of the condition. So with trichotillomania, then you would have things like wigs, elaborate hairstyles, and creative cosmetics, hats. You may avoid going swimming or avoidance of wind if it's blowy because you worry about the bald patch or the areas that you picked. Those avoidance behaviours can also take the form of avoiding social situations, dating, under bright lights, for being found out or people spotting that, and that causes lots of problems. With skin picking, again, it would be wearing long sleeves, polo necks, high collars, and this of course affects your relationship in some ways as well, making sure you're always covered up and people don't see things. And this can be a real problem in this kind of hot summers we're having nowadays. Trichotillomania is commonly associated with young children and adolescents. It has an average age of about 12 years. We do know that there tends to be more females than men, and in my experience it tends to be a kind of adolescent age. So even though they're saying about 12 years, my experience is that people kind of come around that kind of post-puberty between about 16, 17, 18, 19, early 20s. That tends to be a real key age of getting this problem. Often on the back of, say, stressful A-levels is a good example for women in that sense. They have a difficult stress at A-levels, they've got or university, they become stressed, and as a result of that, the trichotillomania springs off this. It's a similar pattern with skin picking, but there hasn't been enough research in the area to definitively say that yet. Some of the things we know associated with skin picking and trichotillomania are depression, generalized anxiety disorders, phobias, and OCD is about 13%. I don't think that trichotillomania and skin picking is a form of obsessive compulsive disorder. It's something different, and that's really important to say. It has its own life, and it is different to OCD. But you can have OCD and trichotillomania or skin picking. And you can see the percentage there for alcohol and substance abuse as well. Okay, some of the challenges in treatment are, the big one is that there is limited public and professional awareness of these areas. I think they're fairly rare, but when they do come up, they're often associated, like I said, with a lot of embarrassment and shame. And when they do come up, they're often diagnosed as OCD. That can be a problem. And the second problem is that GPs may minimize the severity and impact on people's lives. And that is also a key problem as well in some ways, because people don't tend to see this problem very much. But equally well, we know there's a lot of sufferers out there with this problem. So that means it's actually quite difficult to get the right treatment for this problem, which is really surprising because the treatment is actually fairly successful if done well. Okay, hope I'm not boring you or speaking too quickly. My wife always tells me off for speaking too quickly, and I'm trying to slow down. This is my slowed down voice. Okay, here we go. Medication. So we're going to look at treatment now, and which I'm starting with medication because I want to kind of look at it and then rule it out, because there are limited case reports in case series or open trials and controlled studies on medication, and not one drug has been identified or approved for treatment with skin picking or trichotillomania. So if anybody tells you otherwise, run a mile. There are contradictory results and fairly modest improvements with drugs. The medications that have been used, unsurprisingly, are SSRIs or other antidepressants, opiates, mood stabilizers, anxiolytics, and various tropical agents that often GPs try to put on as kind of creams or whatever on the areas. Unless there's association with depression or anything else, I wouldn't see this as a first-line treatment at all. There are other non-CBT approaches, so you can see where this is going to go, that have been used and have been shown to be non-successful. Actually, I'd go as far as I was going to say not very successful, but in fact they haven't worked at all. So don't waste your time on psychotherapy, hypnotherapy. Support groups can be useful if you can find them. They are very rare out there in that sense. But they can be useful if they're focused on a CBT approach. Meditation has been studied, hasn't shown to be useful, nor has breathing exercises alone, although breathing exercises as part of a CBT is extremely useful and something which you'd want to do. Learning relaxation is a really important way of focusing yourself and actually trying to reduce the inattention that these problems can exist. But as part of the CBT, that's a useful thing to do. Diet and exercise are good for you anyway and will help any problem, but they won't necessarily specifically help trichotillomania and skin picking itself, but they're good to have anyway. So we're looking at cognitive behavior therapy treatment now, and there's key elements to that. The first one, and I can't emphasize this enough, is self-monitoring. A lot of people with trichotillomania or skin picking will, just by self-monitoring, each time you do it, by either get it, what I often do with clients when they come and see me is the very first session I get them to go to Paperchase and buy a book and get a really nice one, and every time they pull or have the urge to pick their skin is to write it down. Write it down, and if possible, collect the hair or the piece of skin and tape it in the book straight away and do that. If it's somebody working on a computer, for example, I would get them to create their own Excel sheet that they could hide at work and put on the computer screen so they can actually do it because often picking at the computer while you're working is a very common time, for example, so I want them to record it then. So you would try and find ways to get them to self-monitor straight away. Now what this does is so important. It increases your self-awareness, and increasing your self-awareness is a way of giving you control. And what I often find is just the process of self-monitoring, people can come back and find, oh my goodness, I haven't picked all week, or I haven't been pulling my hair all week. I've managed, every time I got the urge, I thought about going to monitor, and I've been able to stop it. Just that is really key. So self-monitoring is really important. It can't be underemphasized. The second one is what we call habit reversal, and I'm going to, in a minute, look at habit reversal and give you some of the kind of tips on how to do your own habit reversal. Relaxation is useful in terms of, in the context of all the other things on here. So if you, I'm going to try this thing, 1 second. Oh no, I can't. One second. A drawing item. We should have a pen here. So, hopefully you can see my pen. So relaxation is useful in context if it's used with these other things, the habit reversal and self-monitoring itself, and that's good. So do look for times to relax yourself and use that then for stress. What's really important is to face all your avoided situations and build in the strength for that. Like we said earlier, because it's quite an embarrassing and difficult problem to have, people will avoid lots of situations and fear putting themselves out or sitting at certain angles, etc. Within CBT, we'd want you to start to learn to face those things and find that maybe your beliefs about those things aren't as bad as really in real life. We also look for what we call stimulation reducers. Now these are things that actually try and take away all those times where you feel you're going to pick. So you need to be aware of when you're doing it and when that happens. In the same as what we call habit blockers and environmental and routine. So these are times, for example, if you have a big mirror in the bedroom and you have your equipment there for where you know you're going to be and a huge light, we'd want to change all those things around. If you've discovered that environmentally or routine-wise, for example, in the morning you know that you have an hour spare that you tend to hang around or watch TV, and that's the time you pick, we want to then change your routine so you are not in a situation where you can be more likely to pick. Does that make sense? Yes, it does in some way. So a good example is, for me, would be Sunday afternoon. My wife doesn't like football. I like football, so I watch there. I know if I'm stuck in front of the match on a Sunday afternoon, my wife goes upstairs, I'm by myself down there for that time. If I was somebody with trichotillomania or skin picking, then it's likely to start. I'm likely to start to pick. I've got the time, I've got the space, I'm all by myself there, and it then goes into the cycle. So we try to change the routine and the environment so those things are less likely to happen. So we'd kind of monitor those, identify them, and change them to make it harder for your trick or skin picking to take effect. And that's why you then get rid of the amazing pair of scissors you have, or the other bits that you have to use that. Also, we would use CBT for any anxiety or depression that's associated with the problem. We don't use medication unless it's for the depression and anxiety associated. So, self-monitoring. Like I said, it's so key to the first thing of treatment for trichotillomania and skin picking. Increasing your awareness. What you should do is set a baseline for the date, the time, the situation, the thought, your urge, the number of hairs pulled or the amount of skin pulled, and the duration. Recording that, monitoring that, and then keeping it, if you can, saving the hairs or saving a bit of skin as well is important for you to kind of face up to what you're doing and the amount of time and the way this is affecting your life. That in itself can reduce the whole problem massively. If you're still with me, let's go. We're going to look at a guide to habit reversal now. So once you've monitored your problem, you've identified the areas, you've changed your lifestyle and your environment to take away all those areas where you know you can pick. You know at that point, oh, that's a chance where I can do it. I come back from work, I've got 20 minutes there, that's when I tend to, or in the morning I'm showering. If your showering routine includes an extra time or for the picking or whatever, it's important to change that up. So you can change your environment, you've monitored it, you've realized you've started to really face up to the extent of it. What's next is habit reversal. Here's somebody on the phone. and you can see that she's picking her hair in that sense as well. So this is me. Actually, I'm in this room at the moment. She's on the phone. She's concentrating on the conversation, and her hand's gone up, and she's pulling her hair here. Okay, this behaviour happened over years and built up and has become semi-automatic. She's probably not even realising she's doing this at this point. She's getting in, she's feeling it on the specific areas around it. That's quite a common area around here, and it can be really embarrassing for women if they have quite short hairs around this area, or there's kind of baldness around this patch here. What we'd want to do is to get this lady to identify before her hand gets to her hair. So she's got to be able to monitor it and spot when that's happening. Ideally, her hand should have been about here, so it's just coming off the table and going up. That's when we want people to identify it. And it's that movement from the arm being down here to going up that we want to then do the habit reversal on. So it's not, so we stop it before it gets to the hair. It's identifying this. And that's why it's so important to monitor when this happens. If you start to monitor, you will then start to realize, aha, I'm becoming aware of when I pick and the urge to pick. Just here, I can stop it. So you want to use the habit reversal technique before the hand gets to this position. So it was down here where this one was. And before it gets up to here, you're going to use the habit reversal technique just about here. What you're going to do is you're going to do the reverse movement. So the arm would come from here where it was in the earlier picture and swing right back. You see her fingers are spread, and there should be tension in the arm here, right down, spread right here. And you need to hold that for about 15 to 20 seconds. Some of the earlier research was actually much longer, but practically we think that's about enough for you to be aware of it. So when you feel the urge to pick, or pull a hair, as your hand comes up, you would get awareness of that and think, oh, and then you push your hand right back like that. You can see it's quite tense here. You carry on with a phone call. This doesn't look too odd, and you can do this during the day. You can make it look quite normal. It looks like maybe you're doing some sort of yoga pass, but you're trying to stretch your fingers out like so. And there should be tension in here, and you can feel it right down the hand. Here's another shot of this lady doing it, and you can see her fingers are spread wide and doing that. So this may be during when she was on the computer. She felt the urge to pull or pick, and then the hand goes flat out like that. Here with skin picking, you can see the same thing would be happening. So this lady's picking. What we'd ask her to do is to spread the fingers wide as soon as you're able to do that movement and feel tension in the arms that way. Practically, we kind of often go for this kind of movement like this, which doesn't look too bad at all, or the other one is to grab the side of a table here and spread your fingers and grab it there as soon as you see. So this hand's come from here. As soon as it was going down to pick, this lady was able to realize that and bang, push her arm back and hold it there for about 10 to 15 seconds. Now, if you're able to do that 70 to 80% of the time on the urge, you will find you'll gain control of the skin picking. In that sense, it takes a lot of work. It takes a lot of motivation, and you shouldn't give up if you can't do it straight away. The key is to identify and have the urge into your pre-conscious, and then know what to do. In the end, what you can do is you can do the habit reversal as soon as you get the urge, before you even start moving your arms and fingers to go and pick or pull the area of skin. It then goes straight into the habit reversal movement of stretching and placing your hand in such a position like that. Okay, so that's a brief guide to what we would do in treatment that's specific to trichotillomania manual skin picking. We'd also look at, in the cognitive behavior therapy, of course, we'd look at the areas of why this is, the areas of stress around your life and dealing with those areas. But those are the specific techniques of habit reversal, which I believe, with self-monitoring, you can try yourself. You really can. If you can't do that, we are a national unit, so we take referrals from all over the country. And referrals can be made to us or members of your community mental health team or consultant psychiatrist to the address on the screen now, which is Dr. David Veal, or you can email Kay or me. Okay, I think I'm talked out for a bit, and I'm ready for questions.
Thank you very much, Simon. That was very clear. We've got quite a few questions to go through, if that's all right.
Yep, of course.
Brilliant. I'll read them out to you. The first one says, how much training do dermatologists get in recognizing skin picking, and also in diplomatically referring skin pickers to therapy, as often skin pickers only admit to acne?
Yeah, that's a really good question. I know David's looked at this a bit. The answer is not much. They are aware of trichotillomania and they're aware of skin picking, but in my experience, they are not too aware what to do, and that's why you often find they will prescribe topical creams, etc., in that sense as well. It really is something which we would want people to admit to. It's okay. It does sound cringy, but you do need to admit to it if you've got it. You know, don't cover it up by saying exactly on that. You need to tell someone, and then they will get you the referral to us as soon as possible. I would take that last screen, this is what you need to do, take that address to them, and you would find if you say that, they would have heard of the disorder, they wouldn't know how to treat it, but they would know, okay, go and get some help.
Okay, thank you, Simon. We have a question here from someone else that says, up to a few months ago, I had OCD, repeatedly checking locks. As I slowly managed to control this, also I thought I had started skin picking. Is this an either-or situation, or is it in addition to the OCD?
Right, it's not an either-or situation, definitely not. It would be addition to the OCD. So it's not unheard of, but it is very uncommon. So that person needs to go and get treatment specifically for that skin picking.
Okay, thank you, Simon. Hold on.
Okay.
Sorry, I've got another one here. Okay. It says, my husband continually points out that I'm skin picking. Is this a help or a hindrance?
It's difficult because well, in the short term, of course, it's a hindrance. It must be embarrassing. It must be cringy when he's pointing out in that sense. Of course, the reason why he's pointing out is because hopefully it means that you want to say, okay, I need to do something about this now. I need to go and get treatment for this. I know that with lots of disorders, not just kind of skin picking and trichotillomania, but OCD and BDD. You know, people only come when they realise, okay, this is something it's having an impact on my life. It's having an impact on my relationship. Let me go and get this sorted out. If you do that, we would then say, okay, you're in treatment now, and we would kind of probably instruct your husband not to keep pointing it out to you unless you felt ready to or you wanted him to, because you can then do the treatment of habit reversal. But I totally understand in the short term it's not helpful, but it maybe means you want to look at, okay, is this something I need to get treatment for and get sorted?
Okay, thank you, Simon. There's a question here which I think you kind of touched on, or you went through in the presentation. It says, what role do you see for ERP, e.g. exposure to mirrors for compulsive skin picking? It was shown as a treatment in a recent episode of the American series Obsessed, and it seemed a bit risky to me. ERP to feared social situations seems like a good idea, though. Have you got any comments on that one?
Yeah, I totally agree. So we would expose people to their feared situations and let them learn that, okay, they can still go out socially and still live a life and not let these problems affect the quality of your life. But it's not ERP, so it wouldn't be exposure and response prevention in that sense. It would be a kind of graded exposure essentially. Right? That would be useful, but that would be done in the context of actually also learning to control the habit and get it under control. So it does sound like, I wouldn't call it ERP, but the exposure element we definitely would use.
Okay, thank you. There's another question here, which I guess is a big question, and we get asked, I know certainly, is kind of what's the difference really between something like skin picking, hair pulling, and what some people call self-harm? Is it just the extent?
Yes, I mean, in the self-harm literature, skin picking is seen as a form of self-harm, in the sense that it harms the body. So the definition of self-harm is that even if you've done injurious behaviour. Now it may be inadvertent, it may be at a pre-conscious level at sometimes, and it doesn't mean you don't want to die or anything. So in the literature, skin picking does come under a form of self-injurious behaviour, but it's at a different level, and it's in there because it is harming the body. So, I mean, you're pulling out your hair or you're scratching your skin, where often it can be quite extensive where you're bleeding in that sense as well. But that is, I see, a different level to the self-injurious behaviour of the people who are cutting themselves excessively as well. Saying that, there is an element of overlap in the sense that sometimes there can be that relief, that immense relief that happens when you've managed to pick out the hair or have gouged the area of the skin so you've actually managed to do what you want to do. There can be a short-term relief before the distress and anxiety and guilt falls in as well.
Okay, if you're all right to keep going, Simon, there's quite a few questions
Yeah,
popping
absolutely,
up
no
here.
problem.
It says, what is the best to say or do when people point out damaged areas of skin, etc., and ask if you've had an accident?
Yeah, I mean, to be honest, in the short term, I would probably say, yeah, it was an accident, you know, because there's no point in going into the detail. There's no point in dealing with that. If you're trying to face it and you're trying to kind of, you know, wear the clothes you want to wear, then I would definitely be liberal with the truth. I don't know if I was meant to say that, but I would. I think that's reasonable to do.
Yeah. Okay. There's another one here. It says, my daughter has PANDAS, it's PANDAS related OCD obsessions around contamination. She has acne and does pick her face. I'm trying to discern if the picking is related to the contamination issues or if the picking is separate.
That is interesting. Here, that would need to be assessed because I've seen both things. So it could be related to the OCD. If there's a contamination issue, then people may want to pick to check or be concerned. It depends on the meaning of the OCD and the meaning underneath why she's picking in some ways as well. So that would need to be a further assessment before we can make a judgment on that. So it could be either or.
Okay, Sam, can you just explain what this PANDS is, this PANDAS?
I don't know. I know what contamination is, but I don't know what PANDAS is.
Okay, fine. I hadn't heard of it before. Maybe you...
No, I haven't heard of it before either. I went for the OCD contamination. That's an area I know.
Okay, so
I don't know if that's...
if someone wants to, whoever asked that question, if you want to just sort of type in what you mean by that, then that would be really helpful.
That would be helpful. Thank you.
Okay, we have another question. It says, there's a 6-month waiting list in my area to see a community mental health team to even get referred for CBT. Is this a norm across the country? And I think, Simon, if you don't mind, I'll add, what do you do in the meantime?
Yeah, that is always a problem. It's not normal across the country. To be honest, it could be better, it could be worse. I know, because we're a national unit, sometimes, but my advice is always two things. One, make a huge fuss. I know, and I always encourage when people bring up just for inpatient treatment or even BDD treatment, as well as outpatient treatment for these sorts of issues, I always say make a huge fuss, complain to everybody you can, including your MP. I like it when I have maybe 2 or 3 MPs ring up on behalf of patients every year, and that's great for me. I say, fine, you're absolutely right, there should be more recognition and treatment availability. Make a fuss. Go to your panels and make a big fuss, and you can write to the panel directly and say, look, it's 6 months before I can get treatment. What can you do about this? This is outrageous. Everybody should be able to get an appointment. We have a national recognised waiting list that should be able to get an appointment within 12 weeks. Any more than that, then they're breaking their own guidelines. You should make a huge fuss, and it's the patients that make a fuss get seen quicker. So don't lie down. Don't take it lying down. Make a huge fuss. While you're waiting, it's difficult. There is guidelines on the net, and if you look on the website, the problem is that it's varied in quality. Some people say this, some people say that, and therefore it's really difficult to know what to take. And it's a problem that's universal, I think, not just for toxicomania and habit disorders, but for OCD as well. At least there are some really good self-help books. There doesn't seem to be the equivalent literature in this area.
Okay, thank you, Simon. I'd certainly echo that as well, and just let people know, of course, that we have our own advocacy service,
yeah,
and
absolutely, yeah.
that you are entitled to certain things. If you are having problems, you can give us a call, and sometimes we find that a letter from us does seem to help. Also, to say we've got the definition of PANDAS. It's pediatric autoimmune neuropsychiatric disorder associated with strep infection. There you go.
Wow. I'm sorry, we've never heard of that. I'm afraid our unit only works with adults.
Yeah, it says it's often seen in children, and symptoms include rapid onset OCD, Tourette's, and emotional upset. Thanks for that. It's always useful to share knowledge. Simon, I think we've probably only got time for 1 or 2 more. So hold on. There's one here. It says, I'd like to see more literature on CSP at GP surgeries. A shame is such an obstacle to admitting a problem, let alone making a fuss. I think that's probably more a question for us, and I think
Yeah.
OCD Action has to that's part of our role. I think, making sure that people feel that these things are nothing to be ashamed of. And my view and the charity's view is that the more you talk about things, the less of a taboo it becomes. The more you shout, the less embarrassing it is. And I certainly agree with that.
I totally agree with that, and it's a big thing because with these like I say, most of the sufferers are women. It's something which they are very ashamed of and find very difficult with skin picking because of the way it looks and the hair as well. Because they find themselves, they think that they're ugly, they think it's no good, and it's really important you do share it and get the treatment you deserve.
Okay, Simon. Thank you very much to everyone as well. I think we're going to end it there. That's the last of the questions that I can see. Just bear in mind as well that this is recorded. If you go, probably from tomorrow, if you go to the OCD Week website, so it's www.ocdweek.org, you'll be able to download a copy of this. So it's the slide and the audio. If you've got any problems, just call into the office and we'll see if we can help you. So finally, thank you to all our participants and also to Simon. It's very much appreciated.
That's a pleasure. I hope there was something in there for everyone.
Okay, thank you. Good night, everyone.
Thank you. Bye.